Our next talk is by Dr. Carol Wysham, and she's going to talk to us about reducing clinical inertia in type 2 diabetes, a case for early combination therapy. There's Carol behind me. One of the things I find very interesting in your CV is that I look at all the studies that I think have influenced us over the last decade or more, that you've been part of those. Her clinical research trials have included ADOPT, ACCORD, Flat Sugar, LEADER, CANVAS, EMPA-REG, and TICOS. It's a real pleasure to welcome you here.
Thank you very much. Thank you.
And stay on top, right?
Oh, I'm going to try. I want to thank the organizers for inviting me to participate in this very interesting meeting. I'll be talking on type 2 diabetes and the case for early combination therapy. This activity is supported by an independent educational grant from Merck and Company, and it is jointly provided by the NACCME as well as Horizon CME. This is my disclosures. And the learning objectives are seen here. So we're going to outline the benefits and risks of various antihyperglycemic therapies for type 2 diabetes, review the current guideline recommendations for initiation and intensification of therapy, discuss the rationale and role and potential benefits of fixed dose combination, and then design individualized treatment plan for timely achievement of glycemic goals, all in 43 minutes and 44 seconds. So as you well know, the most recent CDC estimates are that there are 30.2 million Americans with type 2 diabetes. That's 12.2% of the adult population. Still about a quarter of them are undiagnosed, and there are increasing numbers of patients with type 1 diabetes, really interesting phenomenon as well. The total cost of diabetes in 2017 is estimated at $327 billion, of which about 2/3 is direct medical costs. So we're going to talk about a patient. We're going to kind of interweave her through the talk. She's 68 years old. She's transferring to your practice. She had gestational diabetes with her last pregnancy 40 years ago, and her diabetes was diagnosed 11 years ago. Given that the people that develop diabetes after gestational diabetes usually do so within 10 years, she's probably had a lot of undiagnosed diabetes as well. She's never attended diabetes education. She says she's going to start the paleo diet so she can stop all of her medicines. She already has peripheral neuropathy, stage 3 kidney disease, and had an MI 6 months ago. Her A1Cs over the time have ranged between 8 and 9%. At this point, she's obese. Her blood pressure is quite high. She does have some peripheral edema and the evidence of decreased sensation. Her labs show LDL is well controlled. Her ALT is slightly high. GFR is 55. Her urine albumin is elevated at 47, and her A1C is 8.7. Her diabetes medications include Metformin, 1,000 milligrams BID, glipizide, 5 milligrams BID, Sitagliptin, 100 milligrams Q-day, in addition to her statin ACE inhibitor. Now, just want to point out that I recognize that she has a lot of points of care that are important besides her diabetes, but we're going to be focusing on antihyperglycemic therapy today. So what is the reason for her control? And this is a polling question. Is it clinical inertia? That is, that her antihyperglycemic therapy has not been advanced as indicated, or that she's non-compliant? Please take your choice. Well, the answer is that this person, for reasons that are very complicated, probably suffers from clinical inertia. So that occurs whenever the healthcare provider does not initiate or intensify therapy appropriately in a timely fashion when therapeutic goals are not reached. And I'm a practicing physician. I actually understand that a lot of times we want to do something and we have barriers, either patients' barriers, not willing to do something, or cost barriers, or formulary barriers. So I recognize that clinical inertia is not just all our fault. There's lots of reasons why it's difficult. Is there a difference between primary care and specialists in diabetes? And the answer is there is a slightly higher percent of patients who are intensified when their A1C is above 8 in an endocrinologist's office. But the difference is small, and it's primarily due to the increased frequency of initiation of insulin, as you can see. No differences in adding new oral meds. So why are we having problems with advancing our therapies? Well, I think a lot of it has to do with patients and healthcare providers not really fully appreciating the progressive nature of type 2 diabetes. the frequent failure of monotherapy, and the fact that patients are going to need to go on to a combination therapy and eventually insulin in most cases. They're very concerned about the side effects of our therapies, and especially because of all the lawyer ads that we have at this point, and the barriers of intensifying therapies, particularly insulin. Of course, the importance of good early glycemic control is something that's not well understood. You're going to see today, I'll present data, as well as Dr. Gavin has in his presentation, similar data. And again, we're not used to using combination therapy shortly after diagnosis, but I just want to make a point that it makes sense to do so in a significant proportion of patients. Because clinical inertia happens so frequently, it continues to be a major barrier to achieving our target A1C. And again, this is a slide you've seen 100 times, but I like to point out, and I actually show this to patients as I'm educating them on the need for additional therapy, is that the beta cells fail over time. So diabetes is clearly a supply and demand problem. The supply of insulin is not sufficient to reach the demand. Yes, they're still making insulin, but because of insulin resistance and lifestyle, they can't make enough. And when I look at insulin therapy, I look at it as being replacement therapy for what's missing. So this was the study that I was referring to earlier. So this is a study of over 100,000 patients from the UK Clinical Practice Research Data Bank. And they looked at patients and separated them out by whether they reached an A1C of less than 7% versus those that did not within a 12-month period of time after diagnosis. And what they found after 5.3 years is that those that failed to achieve good glycemic control early had a 67% increase in MI, 51% increase in stroke, 64% increase in heart failure, and a 62% increase in cardiovascular events. And these were matched for their LDL levels and their other medications, ages, et cetera. So one of the things that I really enjoy when I do educate people about diabetes is the multiple defects that occur. And again, you've probably seen slides similar to this, defining the different organs associated with causing hyperglycemia and diabetes. And again, I could spend the next 30 minutes just going through this. But I think it's important to recognize that it's not just insulin resistance and insulin deficiency, but hyperglycemia occurs because of multiple defects. And we have medications now that can address the multiple defects. And if I had a ability to actually click on the buttons, one of the nice things about this slide is that it does tell you where the different medications work and the impact that they have. And a couple of points I want to show you with this is that when you have a DPP-4 inhibitor, there is absolutely no benefit to adding a GLP-1 receptor agonist because you are completely overlapping the mechanism of actions of those two drugs. The other thing to point out is it's best to try to use medications with complementary mechanisms of action. So for instance, a GLP-1 receptor agonist with insulin and metformin handles 7 of the 8 defects. It doesn't handle the kidney defect, but you can get multiple numbers of the defects handled by that. Okay, so the advantages and disadvantages of antihyperglycemic therapies. I'm sure you're very well aware of the sulfonylureas. They're efficacious, very low cost, but have a high hypoglycemia rate. And first of all, glyburide should not be used in elderly and in patients with renal disease. In fact, I try not to use glyburide on anyone. DPP-4 inhibitors, they have no hypoglycemia risk, no weight gain, very well tolerated. They're amongst the lower of the drugs in terms of their efficacy and obviously have a high cost. They have a warning about potential heart failure risk, which was seen statistically significantly in the Sitagliptin cardiovascular trial. A hint of it in the Allogliptin trial was not seen in the Sitagliptin trial. And then, of course, you need to reduce the dose in renal disease in all but linagliptin. The SGLT2 inhibitors, now there are 4. The advantages are, again, no hypoglycemia risk, weight loss, and now we have proven benefits for cardiovascular events, congestive heart failure, and apparently renal benefits as well. The disadvantages, again, they are intermediate efficacy. They have the impact on the risk of GU infections. This recent warning about Fournier's gangrene that you might have heard about, 12 cases in over 2 million people that have been exposed to these medications, and not clear that there was a cause and effect. Of course, weight gain, the risk of amputations and bone fractures were seen with canagliflozin. There is a minute risk of DKA and a higher cost, of course. TZDs, I think, deserve a little bit of a renaissance. They are high efficacy, no hypoglycemia risk, low cost. Their potential CV benefit has been demonstrated in the past. The disadvantage, of course, weight gain, increased fracture risk in postmenopausal women, and they can exacerbate heart failure and edema. The GLP-1 receptor agonists, again, we now have 5 advantages: high efficacy, no hypoglycemia risk, CV and renal benefit, and CV safety. The disadvantages are their injections, that you may need to adjust exenatide if they have renal insufficiency, and of course these are amongst the highest cost. And then finally, insulin. Let's not forget about NPH insulin, but we also have analog insulins, of which we have not updated this slide for Degludec. It has the highest efficacy, although I would argue that it's not been proven to be more efficacious than the GLP-1 receptor agonists. It has increased hypoglycemia risk and weight gain. And then the cost is, cost of the analog insulins is really reaching a level of extreme concern in our medical societies. But remember, NPH, the Walmart brand, is available for $25 a vial. So keep that in mind as you're trying to help your patients with their costs. So let's start with the AACE guidelines, the American Association of Clinical Endocrinologists. They recommend, as we all do, lifestyle modification, but they have an A1C target of less than 6.5%. Or 1%. What they basically are saying is that for the most aggressive therapy, less than 6.5%, but that we still want to individualize the A1C target. If the entry A1C is more than 1% above goal, they recommend that you start with dual therapy. More than 1%. So if your goal is 7% in your patient that you're treating and their A1C is 8% or greater, you would want to start with 2 medications at the beginning. They still recommend metformin as the first-line therapy, but they list their preferences in order of what they think are most efficacious and associated with the least side effects of weight gain and hypoglycemia. So they recommend a GLP-1 receptor agonist as their second-line therapy, followed by an SGLT2 inhibitor, followed by a DPP-4 inhibitor, and an alpha-glucosidase inhibitor, etc. So A1C above 7.5% or above. If your goal is less than 6.5, you go with dual therapy, again, metformin, and then the same basic listing of medications. And then if the A1C is above 9% with symptoms, they recommend insulin. With no symptoms, you can start with dual therapy or even triple therapy. So how about the ADA? So the ADA says that if the patient's A1C target should be generally less than 7%, but individualized. But if their A1C is less than 9%, you can start with monotherapy. But if it's 9% or greater, you should start with dual therapy with metformin and an additional agent. They recommend that you think about the second agent according to whether or not they have atherosclerotic vascular disease. If they do, then you should use a medication that has been proven to have benefit for atherosclerotic vascular disease, including liraglutide or empagliflozin at this point. And then, obviously, if they fail to achieve good glycemic control, you would go on to additional therapy, and eventually you would end up on insulin. If the patient's A1C is above 10% or they have symptoms, especially if they have symptoms, they recommend you start with insulin as a starting agent and consider other agents as well. All right. So this is new breaking news. The ADA and EASD are coming out with a new consensus panel for starting antihyperglycemic therapy in patients with diabetes. It was presented in draft form at the ADA, which I will show you the draft. It's going to be finalized at the EASD next month. So basically, they recommend that you start with metformin lifestyle, as we always have, and that the very first question you ask, again, after metformin is, do they have ASCVD or do they have heart failure? If they have ASCVD, then you would give them a GLP-1 receptor agonist or an SGLT2 inhibitor. And if the A1C is above target, then you might add the other one. Obviously, if they have kidney disease, it might favor one over the other. If they have heart failure, you would want to start with an SGLT2 inhibitor as long as the kidney function allows you to do so, because of the profound benefits that we've seen with heart failure with that class of drugs. And then you could add the other. The GLP-1 receptor agonists do not have heart failure benefits, so I just want to stress that that's important. And if the patient has heart failure, you should avoid TZD and consider avoiding Sitagliptin. Now, the next questions. They don't have cardiovascular disease. So what about the choices and how you would run through the different choices? Well, you could start with, if you want to minimize hypoglycemia, you have a patient who's a bus driver or an airplane pilot, and they don't want to get hypoglycemic. You can choose one of 4 agents, the SGLT2 inhibitor, GLP-1, TZD, or DPP-4. And then if they need additional therapy, you would add one of the others, remembering that you do not overlap DPP-4 inhibitors with SGLT2 inhibitors. If you need to address weight loss, which who doesn't need to address weight loss in our society, but particularly our patients, you would want to start one of the agents that help with weight loss, and that would be an SGLT2 inhibitor or a GLP-1 receptor agonist. And in that list, you'd want to probably try to avoid using sulfonylureas or insulin early on. Obviously, if necessary later on, you would, of course, not hesitate to do that. If neither of those are major issues, or especially if cost is an issue, you would start with either a sulfonylurea or a TZD. And then if it is A1C is above target, you would add the other agent, assuming no heart failure, and of course, assuming you don't have a patient at high risk for osteoporosis. If the patient needs additional therapy, you would move on to insulin, and NPH insulin should be preferred. And this is a situation where there's a lot of people in the audience who are not old enough to remember using NPH, and you need to know that it has to be mixed well in order to be resuspended, and it does have a higher rate of hypoglycemia at night, so a bedtime snack is appropriate. Well, other things that you should think about as you're choosing agents, not only heart disease, but what about kidney disease? We talked about age and weight. What about their baseline A1C? What about their motivation and their depression? Life may be happening. It may not be appropriate time to move on. And then, of course, cultural and socioeconomic context. So we talked about cardiovascular disease. I really went through this. They did recommend liraglutide over semaglutide over exenatide, and then the SGLT2 inhibitor, they recommended empagliflozin over canagliflozin. And if heart failure, again, consider the SGLT2 inhibitor. And again, this was based on trials that showed, in the region of 35 to 38% reduction in hospitalization for heart disease. And then for kidney disease, remember that the SGLT2 inhibitors have varying labels from between 45 and 60 being the limit below which you shouldn't use the agents. So you need to know the specific labels for the specific medications you're using. Remember, this cardiovascular outcome trials did include patients with a GFR down to 30, not below 30, but at least 30. And what they were able to demonstrate is that the cardiovascular benefits extended down to that GFR, and that there were renal benefits, slowing of progression of kidney disease. So GLP-1 receptor agonists can generally be used with the exception of exenatide down all the way through the continuum with renal failure, with the understanding that the patients may have more GI side effects. They're not recommended in end-stage renal disease, primarily due to lack of study. Now, I just want to point out that the Canadian guidelines have the same guidelines. They really look at the clinical cardiovascular disease first and foremost, and suggest, again, like the U.S. guidelines, to go with agents with CV benefit. And then they have some other suggestions for avoiding hypoglycemia. It's kind of some of the same things that we've already talked about. I think missing on here and both guidelines is the consideration for use of medications with NASH. And of course, we want to use medications that have been proven to decrease fatty liver. Pioglitazone has got the best data, followed by the SGLT2 inhibitors and GLP-1 receptor agonists. So this is a really important study. This is a study where they looked at over 1,700 patients, type 2 diabetes, mean A1C of 8% at diagnosis, put them on metformin, and then based upon their baseline A1C, saw how long it took for them to experience secondary failure. So if they came in with an A1C less than 7%, about 12% per year needed the second therapy. But if they came in with an A1C above 7%, and it didn't matter if it was 8%, 9%, or over, they all experienced a secondary failure rate of almost 20% per year. So 1 in 5 patients per year is going to need a second therapy. And I think many of us don't expect that's going to happen. So again, points out the importance of starting patients' medication on metformin even before their A1C is 7% to try to spare the beta cells to slow down the progression of disease. And this is just another study that shows that the time that we actually give additional antihyperglycemic after metformin failure is quite poor. So if the index A1C was 7 to 8%, it was an average of 20 months, when their A1C was 8%. If their baseline A1C was 8 to less than 9, it was a little shorter, but it was still 9 months before they intensified. And then if it was over 9%, it was still 4.5 months. So just this is another measure of the clinical inertia. We know patients should be treated if their A1C is above 8%, and yet it takes up to 20 months before the medication is intensified. So obviously, when we're thinking about initial therapy, I reviewed this earlier, but just to review, the ADA recommends initial dual therapy when the patient presents with an A1C of over 9%. The AACE recommends if the A1C is greater than or equal to 7.5. And the Canadians recommend initial combination therapy when the A1C is greater than or equal to 1.5% above target. So I challenge you, next day you're in the office and you see a patient with type 2 diabetes, to try to keep the 1 to 1.5% above target in your mind for deciding whether one medication is going to be enough. So we are going to go back to our case. I'm not sure if we have ARS for this. It was intended to. But I want to go back in time. And I want to, 11 years ago, this patient presented with diabetes, and you're seeing her for the first time. She's now 57. You know she has a history of gestational diabetes. All she's taking is hydrochlorothiazide for hypertension. She's totally asymptomatic, routinely found to have hyperglycemia, and you did an A1C, and it was 8.1%. So in addition to referral to diabetes education, which I can't put enough emphasis on, what would you recommend for management of hyperglycemia if you'd seen her at this point? Would you do nothing, give her 3 more months of diet and exercise? Her A1C is 8.1%. Would you start her on metformin and DPP-4 inhibitor as separate medications? Would you do fixed dose combination of either metformin, DPP-4 inhibitor, or fixed dose combination metformin, SGLT2 inhibitor? Or would you do metformin plus a GLP-1 receptor agonist, or would you do other? And the most people chose 5. What I'm going to say is the only wrong answer is 1. You could do any of the others because her A1C is clearly 1% above goal. She needed dual therapy. So there's not a not a completely right answer. I think it's hard to convince a person with newly diagnosed diabetes to take a combination of 2 medications in the first place. And so sometimes we just, I kind of like to use the combination therapies. I tell them there's 2 different medicines in it, but just one single pill is a little easier for the patients to accept than splitting pills into 2 different pills. We know the side effects of the agent. So if a patient has a side effect of a combination oral medicine, we know which one it is, and we can stop the combination and split out the therapy and move on to a different agent. Okay, so combination therapy is well established in several therapeutic areas. I, for instance, would not want to have a treatment for my breast cancer where they started me on doxorubicin, and when that failed, then they put me on cyclophosphamide, and when that failed, they put me on 5-FU or whatever the current guidelines are. They do combination therapy from the beginning. We do it in AIDS, we do it in hypertension. So it's really time that we in the diabetes field start really thinking about combination therapy. And the reasons for it is it's very effective. It helps to deal with some of the clinical inertia because you've got 2 meds at once. You don't have to wait 19 months for the second medication. And we have a lot of evidence to suggest if you use the right medications that you can actually improve beta cell function and slow down the progression of disease, which, believe me, if we're diagnosing diabetes in patients who are 30 years old now, and we hope that they're going to live a normal life expectancy, it's going to mean that if we can postpone the need for complicated insulin therapies longer, that's going to be beneficial for the patient. We want to use complementary mechanisms of action, and you can go back to that slide and look at the choices of medications you can use. You can oftentimes use lower doses of both meds, so less side effects, and you can avoid the long-term consequences of poor control. And again, one of the things about fixed-dose combinations is that it may reduce their copay costs. A lot of times the metformin combinations, the metformin's free. They don't charge anything, any addition for that. It can improve adherence and, again, the lower doses we talked about. Now, just a couple of studies to show the benefits of combined therapy. This is an older study in which patients were either given metformin, which is the orange and blue, or sitagliptin, which is the dark blue, in individual doses, or they were given combinations in the orange and green. So you can see that when you look at the individual, the sitagliptin gives you about 0.8. Max dose of metformin gives you about a 1.3. These patients were pretty poorly controlled with 8.8% average. However, when you gave the combination, you got a 2.1% reduction. And you say, well, why does that? 1 plus 1 doesn't quite equal 2 there. And it is a known phenomenon that you don't get additive benefits from these agents. But if you think about it, you brought the patient's A1C down 2.1% with 1.3% with metformin, they'd be starting at 7.5. And you would not expect to get a 0.8% reduction at 7.5. So again, that's important to keep in mind as you look at this data. But I think the other data, with a mean A1C of 11.2, patients with A1Cs above 10, they enjoyed a 2.9% reduction with a combination therapy. This is patients I would be thinking about insulin in, and yet you can get a really effective reduction even in very highly patients very high. Well, what about metformin and dapagliflozin? Again, just focusing on study number 2, the individual dose of dapagliflozin and metformin, equally efficacious. The combination of the two, again, 2% reduction in A1C. And these average A1C in this study was about 9%. What about the newer SGLT2 inhibitor, utrogliflozin? It is available as a separate medication as well as a fixed-dose combination with sitagliptin. And you can see the individual therapies, whether it was ertagliflozin 5 or 15 or sitagliptin 100, they had about a 1% reduction in A1C. The combination of the two, a 1.6% reduction in A1C. And again, in a fixed-dose combination. A lot of people wonder about, well, what about an SGLT2 and a GLP-1? What happens if you do those together? And this is just from a poster presented last year. If you use liraglutide in the baseline of 8.2, you get about a 1.5% reduction. Canagliflozin, you get about a 1%. And the combination of the two, you get about a 2% reduction. The A1C reduction is not additive, but the weight reduction was additive, and the effect on blood pressure was more than additive. So returning to our patient's current visit, so we're now back in 2018. So she's in your practice. She doesn't like taking her medicine. She wants to do it all with diet and exercise. She's obese, blood pressure is poorly controlled, has a mild GFR reduction, and a mild increase in ALT. So this is an ARS question. So in addition to diabetes education, remember she's never received any, what would you recommend for glycemic management? Would you start basal insulin? Let me just go back. Can we go back? I just want to emphasize her baseline A1C was 8.7%. Okay, now we'll go forward. So would you start basal insulin? Would you stop sitagliptin and start GLP-1 receptor agonist? Would you start an SGLT2 inhibitor? Would you start a fixed-dose combination basal insulin and GLP-1 and stop the sitagliptin? Would you use basal insulin plus an SGLT2 inhibitor at the same time? Or would you stop sitagliptin and add GLP-1 and an SGLT2 inhibitor? So the majority of people chose number 6. I think that's an excellent choice. The patient has good insurance. I think I do appreciate the fact that the audience recognized that basal insulin by itself and an SGLT2 inhibitor by itself is unlikely to reach goal. I think it's also unlikely a GLP-1 is going to reach goal because you're going to be removing some glycemic efficacy from stopping the sitagliptin, but it would be an option that would be reasonable. I think a fixed-dose combination basal insulin GLP-1 would also be a reasonable option as well as the number 5. So again, not a right answer, but some better than others. So what's the take-home from this presentation? Well, type 2 diabetes is characterized by a progressive deterioration of glycemic control. Stepwise models of clinical practice for type 2 diabetes suffer from clinical inertia and frequently fail to meet long-term treatment targets. Combination therapies have been shown to be safe and effective and should be used early in the disease process. And of course, I hope that we had enough time to show you at least some of the newer recommendations about how you might individualize your therapy by the patient characteristics, and of course should always include the patient's values. So with that, I'd like to take the last few minutes for questions. I think we have about 7 minutes.
Thank you very much for that excellent presentation.
Thank you. Thank you.
I want to remind everybody that we're going to have all the people of the morning get back together at noon to answer some of these questions. But Dr. Wysham has about 7 minutes to answer questions. Here's the question. Of the newer diabetes medications, is there an increased risk for sudden death or QT prolongation?
Not that I am aware of. The only cardiovascular, of course, we've seen the cardiovascular benefits of liraglutide and of empagliflozin. The canagliflozin has a cardiovascular benefit, but hasn't received a label update by the FDA as of yet. The only thing that might be considered a risk, which is not borne out in the clinical trials, is the increased pulse rate that's been shown with the GLP-1 receptor agonist, but no changes in the QT intervals.
Okay, could you address A1C goals for the age groups greater than 70, greater than 80, greater than 90?
Okay, so I'm going to give you a tongue-in-cheek answer before I give you the American Diabetes Association answer. Once they hit 70, I take their age divided by 10. If they have, and that's my A1C target, if they have cardiovascular disease, even someone in their 60s, I will choose a higher A1C. Remember, in the CORD trial, we proved that 7 to 7.9 in the patients with established cardiovascular disease was associated with less mortality than attempting to get patients' A1Cs to less than 6. But the ADA and the American Gerontology Association recommends that if you have an elderly patient, they define it as 65, and I'm way too close to that to be considered elderly, I have to say, but they consider that 65. And if they have no comorbidities, they're free living, that it's appropriate to try to get less than 7. But as they become more disabled, that you might say, for instance, they're still living in assisted living, they're still doing most of their own ADLs, and they don't have any significant memory loss, that less than 7.5 would be appropriate. As you add on morbidities, less than 8.5 then for the patient who is in a nursing home who might have advanced dementia or advanced cardiovascular disease or other complications. So that's their cutoff, 7, 7.5, and 8.5. But I think I think I individualize my patients, and if they're on insulin, I certainly abide by those guidelines. But if they're on agents that are not associated with hypoglycemia and doing well, no side effects, and their A1C happens to be 6.5, I don't back off on medicines unless, again, financially, sometimes that's the appropriate thing to do, or sometimes the patient wants to do that when you give them the guidelines.
Okay. What about some of the side effects of SGLT2s that relative to amputations, fractures? And if there are some, is it specific to one drug, or is it a class effect?
Well, the latter question is a $1,000 or $1 million question. Right now in the clinical trials, only canagliflozin was associated with increased risk of amputations and fracture. And what I can tell you is the fracture data comes from the very first part of the CANVAS trial, happened within the first 12 weeks. And it looks to all of us that were participating that it was related to hypovolemia, hypotension, and falls. We were told not to change the blood pressure medicines or the blood sugar medicines, for that matter, when we started the study drug, the canagliflozin versus placebo. And we now know very well clinically that when we start these agents, we need to tell the patients to hydrate aggressively. I generally stop their diuretic as long as their blood pressure is at goal and they don't have severe heart failure, obviously. And in doing so, I haven't had any falls since. I had one early on. Patient fell and had a fairly significant injury because of hypotension. So don't let your patients get hypotensive. Remember, look at the blood pressure, pull back on their blood pressure meds because you know you're going to lower them at least 5 milliliters of mercury. And in the case of the elderly, it can be as much as 10 millimeters of mercury from the starting dose of the medication.
How about if they have a higher risk of peripheral vascular disease?
Well, I was going to get to that because
Sorry, jumping ahead.
No, you're fine. No, you're fine. So the interventional cardiologists, when they saw this data, and we kind of all got around to think about what in the world was going on here, there's no plausible mechanism for it to be directly related to SGLT1 or 2 effects on the periphery. But we too think that this is a hydration volume issue. And canagliflozin is of the most, the word I want to use, it's the most potent of the SGLT2 inhibitors. And so therefore, the risk of dehydration and hypovolemia is greater. So how do I handle this in clinical practice? Well, we do foot exams on our patients, and if they have peripheral neuropathy, we do them at every visit. Our MAs do the foot exams. So we are identifying patients who have peripheral neuropathy. We're getting them in the right shoes. We're counseling them aggressively on how to take better care of their feet. If a patient comes in and they have a cold foot or they have a sore on their foot, I don't start these agents. Now, I think patients with peripheral vascular disease really benefit. They got some of the best benefits from the medicine, so I wouldn't want to withhold them. But I wouldn't start it with an active ulcer, wouldn't start with infection, wouldn't start it with a cold foot. I'd let that be taken care of first, use other agents, and then maybe revisit it. And I tell patients when I start it, if they don't have any peripheral vascular disease, I don't even go there. I don't even talk about the amputations. But if they have peripheral vascular disease, severe peripheral neuropathy, I tell them to do daily foot exams, and if they develop an infection or an ulcer, stop the medication. Because that's where the problem was. Not that it increased the risk of an ulcer or amputation, but that it impaired the healing of an infection or an ulcer. So that's how I handle it, and I don't know if you have any different opinion of that.
No, just I think.
Right, I think I wouldn't start any of the SGLT2s in a patient with an acute infection or an ulcer.
Okay, we have about 50 seconds here. Quickie, do people that take SGLT2s get an elevation of glucagon, and should we treat that?
That's a really very good question. Somebody very sophisticated asking questions. So yes, it appears as if when you cause loss of glucose in the urine, that there's a compensatory mechanism to increase glucagon. And that, of course, will cause gluconeogenesis and release of glucose from the liver. However, if the patient's A1C is at target, there's no reason to do that. But it does make for a very strong argument for using a GLP-1 receptor agonist as your next step if the patient fails to achieve glycemic control. The DPP-4 inhibitors do not have enough glucagon suppression to overcome that effect.
They combine the pill, but our time's up. Thank you very much.
You're welcome. Thank you for your attention.